Has everyone already forgotten everything from the first lecture? Fantastic. So we're going to hit the ground running. So go back and review that video if you have any questions after this. But remember we were talking about cell signaling. We were talking about how cells are able to communicate with one another. This is essentially how a lot of drugs are going to be working as well. I want to cover some of the main types of drug receptors that we're going to be coming across when talking about medications, and we'll talk about some specific examples and how they're going to come up later on. Now, if I mention a specific drug in class here and I say, hey, digoxin does this, I'm not going to have you memorize that for the test specifically. I'm just using it to illustrate an example. Next semester and the following semester, that's when you have to memorize things like, what does this drug do? Like, how does it work? Things like that. So just kind of keep that in mind. Don't freak out if you don't remember every single drug I talk about, really just for more illustrative purposes here. Don't forget you have the sticky board that you can also use to post questions up if you feel a little too shy to ask them in the middle of class yourself, okay? So these are the four main types of drug targets we're going to be shooting for. We have things like ion channel receptors, we have G-protein, enzyme-linked, and then intracellular receptors. So getting into it in terms of where they're actually working at, you can see here that most of the receptors you're going to deal with tend to work on the cell surface here, right? So most of the time you have proteins that are kind of sitting there on the cell surface that will be the point of contact for many of the medications you're going to run into. You also are going to have some that are going to be lying within the actual cell itself, and maybe targeting specific proteins and maybe targeting DNA, whatever the case may be, but that's going to be more intracellular. To break it down further, you can see that we'll have our ion-linked, G-protein, and enzyme-linked receptors here on the cell surface, okay? These are really going to be the first points of contact, and then you're going to find there's several downstream sort of effects that will happen based on whatever interaction's happening here. So first off, I want to talk about the ion channel-linked receptors. So what do you think these do when they activate? They allow for flow of ions, absolutely. So you've probably encountered many of these when talking about physiology, correct? Does it cover like cardiac physiology? Perhaps, I think you have. Things like neurophysiology, perhaps you've come across some of that. This is the same stuff we're talking about here, right? So again, when you think about things like GABA channels or you think about sodium channels, these are all sort of ion channel linked receptors here, meaning that whenever I activate one of these with a medication, you're going to find that it tends to open up and will allow ions to either flow into the cell or out of the cell, depending on what type of channel it is, right? It could be non-specific. It could be allowing things like sodium, potassium, calcium through, or it could be very specific to where it maybe only allows for chloride to flow through, okay? Now, typically, do you think this will go along or against the concentration gradient? Typically, it's going to go along the concentration gradient, which just means it goes from areas of high concentration to low concentration, right? So, for instance, when you're thinking about things like, thinking back to the cardiac physiology, and you're looking at the differences in the intracellular versus extracellular contents of sodium, right? Has anyone ever seen like what a normal sodium level is in the blood? You know what it is? Usually 135 to 145, right? It's a number you'll become familiar with. That's a very high concentration outside of the cell. What do you think it is inside the cell? Pretty low. So that way when you open up one of these channels, guess what? Sodium's going to flow into the cell. That's how you have your action potentials in the heart, right? That's how you have action potentials in the neurons. These are things flowing along the concentration gradient. Now we can pump things against the concentration gradient, but those are different types of receptors, okay? We'll talk about those in more detail a little bit later on, okay? And you can find that these channels, they will have different subunits that make up the specific type of channel. This is why you can have different types of GABA channels. You can have different types of sodium channels based on the different subunits that are here. And so, for instance, by changing one of these, you may change what type of ion can flow through. You may change what kind of ligand can actually bind to it. Anyone remember what that term ligand means? Yeah, anything that can go in and bind to it, whether it be an endogenous chemical we produce or something exogenous like a medication, right? So anything can come along and bind that up depending on the subunits that are present there. And those will make up a lot of the different types of receptors you're going to run into, right? So if you see things like different types of nicotinic channels or different types of acetylcholine channels, that's mainly the difference is the change in those subunits that are there, okay? And again, you can find that there's many different varieties that are out there. A lot of it has to do with the cells and how they're actually splicing and transcripting their DNA into different proteins there. So that way you're going to find that certain, say neurons are going to have one variety of channel that they'll produce based on their DNA and based on the situation it's called for, versus say something like in the GI tract, right? There are ion channels everywhere, but depending on where it's at, what type of tissue you're dealing with, you'll find that those subunits will change. And that way you can find different activities depending on where you're at in the body, okay? So just to give an example here, here's some nicotinic acetylcholine receptors. Does anyone know why we call them nicotinic receptors? Binds to nicotine. That's the first thing we found that actually bound to those that we used to test that, right? So, but normally, what does our body produce that binds to that? Acetylcholine, right? Your bodies don't generally produce nicotine on its own, right? Let's try a really calm, cool kind of individual, maybe not. But you can find there's different types here, right? So it's NM, NN, CNS, different ones that will allow for different ions to flow through. So as an example, the CNS variety of nicotinic receptor allows for calcium to flow in, right? Calcium is a very important cell signaler, as we'll find here. Ones on the skeletal muscle are going to allow for sodium to flow in, okay? So again, don't memorize these specific examples. Just know that by changing the composition, by changing the subunits, you can get very different effects depending on where you're at in the body, okay? So, to give you some examples of drugs that interact with this, well, we just mentioned nicotine being a very good example of that. That can interact with these nicotinic receptors there in the CNS, so kind of what provides that sort of calming sort of effect you see with nicotine there. But also you can do other things, like for instance, has anyone ever heard of this substance called curare? Right, it's actually a paralytic. So if you ever hear like poison dart frogs, ever heard of those? They're like these individuals would take these little poison frogs and they would take them and dip their little needles into it and then use blowguns and paralyze people. That's essentially the same thing, right? We're using a very similar chemical there. They actually can block those nicotinic channels and prevent your skeletal muscle from firing, right? Leads to diaphragmatic paralysis, leads to respiratory failure and death, okay? Other things, right? So has anyone ever heard of a barbiturate, like phenobarbital, anything like that? No one's ever heard of that? It's a pretty old school drug, but we still use it nowadays. But tranquilizers, anyone ever heard of Xanax before? Or Valium, right? They work through very similar channels here, and they actually work on GABA receptors. GABA receptors allow for chloride to flow in. Now, when you think about someone taking the Xanax, how do they usually like appear? Are they like super excited and they want to jump around, clean their house? No, they're pretty chilled out, right? And again, that makes sense because by activating GABA channels, chloride flows in that leads the neurons to have a harder time activating, right? So again, think about these mechanisms in terms of how we're going to be changing these receptors, how we're going to be causing them to activate or not activate, as the case may be. And you find you can provide very drastically different physiologic effects depending on what we're doing to those channels there, okay? Calcium channel blockers is another really good example of things that can help to lower blood pressure by preventing calcium flowing into smooth muscle that allows it to relax, right? And that allows for the the smooth muscle around the vessels to actually relax and cause blood pressure to lower, right? So these are all good examples of ways that we can interact with these ion channels, okay? So up next, we have a very diverse set of receptors here called the G-protein-coupled receptors. Now, again, getting the structure memorized is not so important here, but this is typically what they look like. So, again, imagine this is the cell membrane, right? It's that phospholipid bilayer. I'm sure many of you remember from biology. Maybe? Yes? Okay. Anyway, so you're going to find that these proteins will be situated right there in the membrane and will have a signal binding site. And basically, this is where the drug or the ligand will come and bind to it. And then you'll find there's some downstream effects from here, right, that will cause different cellular actions to occur based on whatever's binding to it. Okay. So, and there's a huge number of different ones here, right? So you can find even in mice, there's about 1,000 G proteins just for smell of the sense of smell by itself, right? So again, there's a lot of different varieties that are out there, a lot of different drugs. About half the drugs we know are going to be interacting with G protein linked receptors. And I'll give you some examples of that in just a little bit. So these are important because they are so ubiquitous throughout the body. We're going to find that a lot of different drugs activate these. And in fact, just to give you an example of kind of the diversity even within one specific type, you can see here that one ligand can activate more than one type. There's 15 different serotonin G proteins. They're all activated by serotonin, right? So different varieties of the same serotonin receptor, they can all interact with that. And so what does serotonin do for us? Anyone know? Mood's a big one, right? So you think about things like SSRIs, like serotonin reuptake inhibitors used for depression. So we'll talk much more about that later on. But depending on how we activate or not activate different types of serotonin receptors, you may be able to help someone with their nausea, vomiting. Anyone ever heard of Zofran before? That affects serotonin receptors. We can affect things like schizophrenia. We can affect all sorts of different organ systems just based on interacting with different varieties of serotonin receptors. Migraines is another big one that interacts with these serotonin receptors. Okay, so a lot of variety here with the G proteins. So anyway, what happens with these is that you're going to find the ligand is going to bind to the protein itself. That is then going to cause an activation of some of the further G proteins that will be kind of connected to the intracellular component of the protein here, right? And so, again, don't get too bogged down into the details here, but I'll kind of briefly go through what's happening here. Essentially, when you have a signal molecule come along and bind this, you're going to find that this inactive G protein becomes activated, right? So essentially what it does is you have this GDP. Anyone know what that stands for? Gross domestic product. No, not that.
Right.
Is guanosine diphosphate, right? So it's kind of an analog to adenosine diphosphate, right? Now, what happens if I throw an extra phosphate group onto there? It becomes more energetic, right? Just like ADP gets converted to ATP. ATP is used for what? Energy all throughout the body, right? So GDP gets converted over, right? So it'll pick up a phosphate group. So this does require some energy, and then it will then have an activated G protein that will then go along and interact with whatever else it's supposed to interact with. And we'll talk a lot about secondary messengers here in just a little bit. That's kind of the follow-up to this section here. But again, it can have a wide variety of different things. This can include things like sense of smell. A lot of G proteins there in your nose that can help you to detect differences in smells of different substances. It can affect things like I mentioned, nausea, vomiting, migraines, all kinds of things from here on. So, and typically what you're going to find is that the activated G proteins will interact with some sort of target protein, and then that will then cause some downstream effect here, right? So maybe this activates further protein kinases, right? Anyone know what a kinase does? Phosphorylates, right? Adds a phosphate group onto something, right? So maybe you activate a protein kinase, or any number of things can happen from here. But just know that the ligand binds to the G protein, that activates the G protein complex, and then we'll go and have whatever effect it has. Okay, and we'll go into more details on those examples in just a few minutes here. Okay. Now again, you can't have it remain active forever, so eventually once it loses that extra phosphate group and that GTP turns into GDP, then it inactivates and it kind of resets itself, right? Because you wouldn't want these proteins to be active forever, right? No, right? You want to be able to go back to baseline. Again, that's homeostasis, right? You want the body to get back to baseline at some point. But just to give you some examples here, right? So imagine different G proteins. Don't memorize these examples. These are just examples, right? So again, looking at this one here, we have the GS protein. This has to do with beta receptors, right? What do beta receptors do for us? Beta adrenergic receptors. You guys covered the fight or flight response, right? So if I said pop quiz, would anyone's fight or flight response activate all of a sudden? Most likely, what do you think your heart rate would do? Probably go up, right? These are the beta receptors we're dealing with, right? Those are G proteins. Essentially, you're going to find that things like catecholamines like epinephrine and norepinephrine would then bind to those receptors. It will cause, in a secondary effect, right? The G protein gets activated, and then you'll see things like cyclic AMP increases. That will then cause your heart rate to go up, right? Cause your blood pressure to go up. Other things like, GOLF, this olfactory, right? That helps with smell, right? So again, this is important because this is kind of the intermediary between the drug or the ligand to the secondary messenger, and that's the next section we're going to talk about in just a little bit. But again, these are kind of the mediators of this process here, right? These are the points of contact, and then they go and have some downstream effect later on. Okay, we'll cover these in just a bit. Next up, we have another important group here called the enzyme-linked receptors. So as you might imagine, these have enzymes directly attached to them, and so these are going to work a little differently than what the G proteins will, but they're also a little bit higher variety in terms of the different ones here. So as an example, you can have things like guanylyl cyclases. You can have things like different types of kinases here. The most important one we're going to talk about is going to be this tyrosine kinase. This is really important for drug as far as drug targets go. This is an up and coming one, as we'll see in a second here. Typically, these are a little bit slower in response than the G proteins tend to be. However, they could be also linked to more kind of powerful sort of effects. So as an example, insulin receptors are a type of enzyme-linked receptor here. And we'll see some of the effects here in just a minute when I illustrate that. And again, as I mentioned, tyrosine kinases are the most common enzyme-linked receptors you're going to run into, especially in terms of drugs. The reason why they're so powerful is because their downstream effects, their secondary effects, tend to have effects on roles in terms of like DNA synthesis, right? They can affect things like mitosis of cells. They can do things like helping with the proliferation of the immune response. So as an example, this is becoming a very powerful target for a lot of chemotherapeutic drugs. Now, is anyone at least familiar with kind of common effects of chemo drugs? Are they very good effects? Like, they're really nasty drugs. Like they're basically poison because they can't really tell cancer cells from human cells or normal healthy cells. However, by targeting specific tyrosine kinases that maybe only cancerous cells express, you can be much more focused, and you can be much more targeted, and you actually limit a lot of side effects because they're only hitting the cancer cells that express these proteins here. So this is why we're really looking at these, because again, if I can affect things like DNA synthesis in a cancerous cell, is that cancer cell going to keep replicating? Right, so then you now have stopped that cancerous growth, right? It's a good thing, right? Then you can try to get rid of those cells through other means. Anyway, so lots of different important roles that these are going to play here. Insulin receptors, again, also very, very important. So just to give you an idea how these work, basically you're going to find that they have kind of two halves of the receptor itself. It requires two signaling molecules to come and bind to it. When that happens, they will then dimerize. You know what that means? They just kind of come together, right? They just kind of double up essentially, right? So they dimerize, they come together, and then you'll find that these will then cause phosphorylation, right? So it will use ATP up to then phosphorylate, and then it has whatever downstream cellular response you're looking for, okay? So what do you think, say, for instance, like an insulin receptor would cause to occur? Anyone know? Thoughts for glucose transporters to be expressed at the cell surface, right? So let me show you an example of that in just a second. Actually, I don't have that up here. I'll probably show it to you a little bit later on. But just as an example, by activating insulin receptors, that causes the cells to say, hey, well, we want to uptake more glucose. Let's put glucose transporters up into the cell membrane, and then you can then take that blood sugar out, right? So again, you'll find very powerful effects from the tyrosine kinase receptors. The last one I'll mention here is going to be the intracellular receptors. This is where a lot of different steroids and hormones tend to work, right? So you think about things like testosterone, estrogen, progestins, cortisol, all those different things tend to work directly within the cell itself. So it has to go through this membrane here. We'll talk about how that occurs a little bit later on, and then activate some sort of intracellular component, right? Whether it's DNA or whether it's going to be certain proteins, endoplasmic reticulum, whatever the case may be, it'll be within the cell itself. So this is what differentiates it. It's not on the cell surface. And again, looking at typical hormones, you may run into different steroid types. Notice here they all have a pretty similar structure for the most part. But basically what they'll do is they'll get down into the actual nucleus, and then they can change what you're transcripting, right? They can change what proteins you're actually producing or not producing, and can have pretty powerful effects. So as an example, say for instance I were to give you, say cortisol, right? Anyone know what cortisol does for us? It works with protein catabolism, right? So again, it's usually more of a catabolic sort of hormone, causes muscle breakdown. So that way we can use it for energy, right? It's usually a stress hormone. Most of you probably have elevated cortisol levels since you've gotten into school, right? I would imagine so, right? So you're going to find that things like glucose levels are going to go up, and a lot of it's based on its effects on the DNA, right? We use this a lot for a lot of allergic conditions or inflammatory conditions because they're so powerful. By working at the DNA, you basically affect inflammation from the very top of the pyramid down essentially, right? So these are very powerful medications here that can work on the DNA itself, okay? So anyway, so here's a summary of the different receptor types. You can kind of go back and review those. Again, have a general idea for what they're doing. The specific examples I'm not going to quiz you on, right? I'm not going to say, what does the GS protein do on a test, but I may say, for instance, what happens once, say for instance I have an intracellular acting drug, where's it going to be working at, right? I'll say G protein, tyrosine kinase, or like, the DNA, right? And you say, well, this is the only intracellular target, okay? Something like that. That's a really bad example off the top of my head, but have a general idea for how these proteins are going to be working here. Got it? If I say, this type of receptor has, when it's activated, causes sodium to flow in, you would say, what kind do you think it is? Like an ion linked, right, or ion gated channel there, right? So again, this is like the easy portion of your pharm curriculum here. So a lot of his definitions, concepts, it's not going to be really hard hitting, like brain bending sort of examples. That's for next semester, okay? So just don't stress too much about it. Anyway, so any questions on that? All right, so getting into the next section. All right, so now we talk about the second messengers, right? So the first messenger would be what? The ligand, right? That would be our drug or endogenous component that we're producing. That's going to be the first messenger here. The receptor is what we just talked about, whether it's G protein or ion gate or whatever the case may be. But now we have the second messenger. These are what's actually going to cause changes within the cell itself to have whatever effect you're looking for, whether it's to lower blood pressure, increase blood glucose, whatever the case may be here, right? Some of the more common ones you're going to run into include things like cyclic AMP. Yeah, laser pointer. We're going to have cyclic GMP, and here's where I'm going to give you some very specific examples of how these are going to be working in terms of drugs. And then calcium. Calcium tends to be a very important intracellular signaler, as we'll see in just a little bit. And then you also find these tend to be, they can be activated based off of enzymes, right? Things like tyrosine kinase receptors we looked at, they can be activated by ion channels, as we'll see in just a little bit. So keep in mind that they can be activated through several different means. Any of the receptor types can lead to activation of second messengers, okay? So cyclic AMP is the first one we're going to talk about. The important enzyme here is going to be adenylyl cyclase. So imagine you have something that is activating a G protein. That G protein will then go and activate adenylyl cyclase. That will then change ATP, we convert it over into cyclic AMP. Okay, so we'll take the high energy molecule, convert it over to cyclic AMP, and then you're going to find that it has whatever physiologic effect it has within those particular cells, right? So for instance, when you have that activated within the heart, you're going to find the heart rate and contractility go up, right? You're going to find if you did this in the, say in the vasculature, you may find increased blood pressure, right? Different effects you're going to see depending on the type of tissue that you're dealing with. So some examples of things that work through cyclic AMP include like ACTH, glucagon, thyroid stimulating hormone, and vasopressin. Anyone know any other names for vasopressin? ADH, which stands for antidiuretic hormone, right? Sometimes I put it up on the board. Some people are still like, I don't know. It's on the board there. It's right there, right? Give it away. What does that do for you? Sodium. Yeah, a lot of water retention you're going to find is a big thing with that. We'll talk about that in just a second here, how those actually work. But so imagine here, and again, this is a good pictorial example of how this works. Imagine you have a G protein here. This is getting activated by a medication or a hormone. Again, this is the first messenger. It'll then activate this process here, and this is where adenylyl cyclase gets its time here. Adenylyl cyclase will then convert ATP to cyclic AMP, and then whatever downstream effect occurs from there causes the physiologic change, right? So it's increasing contractility, heart rate, blood pressure, whatever the case may be. That's the general process for how these work. And again, this is an amplification sort of process. You can find that the G protein may activate several adenylyl cyclases. So that way it's not just a one-to-one sort of thing. That would be very inefficient. By activating it once in a G protein, you may find that a lot of adenylyl cyclase gets activated, a lot of cyclic AMP gets produced. So that's the reason why there's kind of multiple steps here, because it allows for that amplification to occur. So other things that could occur here as well, like imagine you were to say activate this protein kinase A, that could then go down into the actual nucleus and change things like gene transcription, right? So again, even though you're still working through a cell surface receptor, you can still find deep changes occurring here based on the secondary messengers and how those actually work, okay? So let me give you some examples of how this works more specifically. So for instance, when I'm looking at things like excretion of glucagon, right? So I release glucagon into the body. When does the body normally release glucagon? Blood sugar levels are high or low? Typically low, right? So they'll go and interact with the liver, and when what happens from there? You're going to make new glucose, right? What do you call that process? Gluconeogenesis, right? It's right there in the name. So that's part of that process there. I'll show you an example of what that looks like in a moment. Things like conservation of water in the kidneys through vasopressin, things like calcium homeostasis via parathyroid hormone. These are just different examples of where cyclic AMP is really used to help regulate a lot of these processes here, right? So let me show you some pictures. I think it kind of helps drive it home a little bit better. So imagine, and again, I'm not going to get super in the weeds with this one. I just kind of want you to focus on the highlights here. But imagine you're having that stress response, right? So I say, one of you come up here and give the rest of the lecture. You may have a stress response, right? So epinephrine would be coursing through your bloodstream, right? It would activate a G protein, which would then activate adenylyl cyclase. And then I say a lot of stuff happens here. I'm not too worried about that stuff. But imagine, again, this is a liver cell, right? This is a hepatocyte. Now, normally, when you're in a fight or flight response, do you need a lot of energy? Yes, because you'd want to run away from this room as fast as possible if I told you to give the lecture, so you need glucose for that. So by activating this within the hepatocyte, you're going to find this will eventually allow for the conversion of glycogen eventually over into glucose, right? Glycogenolysis leads into gluconeogenesis, and boom, now I have glucose being released into the bloodstream. Now I have more energy to run away from whatever stressor is there, right? Or if I need to fight the stressor, I would not recommend fighting me. I will go down very quickly, but maybe it's a way to get out of class early. Who knows? Anyway. Point being is that this is the process here, right? So epinephrine leads to increase in blood glucose, but it's through the secondary messenger system through a G protein receptor. Anyone familiar with what this is? What this is called? The nephron, right? Have you covered renal physiology yet? Yeah, so you should know nephron, right? Everyone's seen a nephron before. What is this? Glomerulus, and then you have what's this here? Loop of Henle, and you have your distal convoluted tubule and your collecting duct. So this is where vasopressin really comes into role here. We're going to find that by putting these aquaporin channels into the collecting duct, right? So again, this is through adenylyl cyclase. It'll lead to aquaporin channels being expressed here in the collecting duct. That will then allow for reabsorption of water, and that allows for that water retention, right? So again, when you're having an antidiuretic sort of state, you don't want to pee, you want to hold on to that water there, right? That increases blood volume, gets blood pressure up, things like that. Anyone remember a substance, maybe, I don't know if I mentioned it to you or not, but anyone know what inhibits the release of antidiuretic hormone? Substance you may have consumed perhaps on the 4th of July? Alcohol actually does that, right? Anyone ever heard the term breaking the seal? Yeah, breaking the seal. Why do you pee so much when you're drinking alcohol? Because it inhibits antidiuretic hormone release, and so you don't have all those nice aquaporin channels there in the collecting duct, and so that urine just goes straight by into the bladder and eventually out into the toilet, right? So again, you can see how different medications, because alcohol is a medication itself as well, can interact with the system here, right? So by inhibiting the release of antidiuretic hormone, you never have that process activated, thus aquaporin channels stay within the cell, not on the surface where they actually work, okay? Kind of make sense? A little bit. That can wow your friends next time you're out. Not that you guys would ever consume alcohol while in school, but assuming some of your friends do, perhaps, or family members, you can say, oh, why do you have to go to the bathroom? Well, I can tell you why, exactly. Anyway, looking at the effects on the heart here. So imagine you have a sympathetic nerve terminal here that is releasing catecholamines like norepi onto the heart, right? So here we have a myocyte here. Here's a beta-adrenergic receptor. So norepinephrine will then activate this, activates adenylyl cyclase, cyclic AMP is produced, and then this actually allows for opening of calcium channels, right? So now we have calcium channels being really coming into the cell. And why is calcium important for muscle contractions? So it allows for the actin and myosin to really interact with one another. So again, the heart's a muscle. So by having more calcium come in, that muscle is going to work more effectively, right? You're going to be contracting it harder and faster in order to get more blood pumped out. Okay. But again, it's through that cyclic AMP sort of pathway there, right? That's the secondary messenger we're dealing with. Now, cyclic GMP is going to have some different actions here you're going to find. And again, not all of these are working within a silo. Oftentimes, cells can express multiples of these, and they can have either antagonistic or synergistic sort of effects, which I'll show you in just a few seconds. But cyclic GMP is the next one we're looking at. And in fact, if you know how cyclic AMP works, you basically know how cyclic GMP works, essentially. We're going to find that instead of having adenylyl cyclase, we'll have guanylyl cyclase, right? That is actually going to turn cGMP over, or we'll actually have guanylyl cyclase activate and form the cGMP here. And so you'll find this actually works in several different types of tissues here. So for instance, in the intestinal mucosa, it can regulate things like ion channel conductance. Why do you think that would be important in the GI tract? Because it affects things like water balance within the stools, right? So again, if I have excess water within the colon, what do you think it's going to lead to? Diarrhea. If I have too little water, what is that going to lead to? Constipation, right? So you have to keep a balance here, and cyclic GMP can help with that. More importantly, we'll talk about how it works actually in the vascular smooth muscle. This is really important for helping to regulate how constricted or relaxed those muscles are, which can affect what, do you think? The vascular smooth muscle. If it's really constricted, that leads to what? Hypertension, right? Or if it's very relaxed, it can lead to hypotension. So I'll show you how that works in a second here. And again, this is going to be that direct vasodilation, that increased blood flow. So imagine here you have a smooth muscle cell. You can find that when you have an agonist come and bind to this guanylyl cyclase, you'll turn GTP over into cyclic GMP, and that can lead to several downstream sort of effects here. So for instance, it may lead to increased calcium being sent out of the cell, or decreased calcium levels in the cell, and that can actually lead to relaxation of that muscle there. Okay, so again, by relaxing that muscle, if it's surrounding a blood vessel, that allows for vasodilation, allows for hypotension to develop there. It's important to know how these systems are regulated, though. So as an example here, here's an enzyme that can interact with cyclic GMP to actually help to reduce those levels. Because again, I don't want this to stay activated forever because I need to go back to baseline. So there's an enzyme called phosphodiesterase that can actually come and actually metabolizes cyclic GMP, converts it back over to just a regular guanosine monophosphate, and thus the system kind of goes back to normal. Okay, so actually now we can see there's two different targets here for drugs to actually interact with the system here. So I could have an agonist come along and actually activate this to make more cyclic GMP, or on the flip side, actually I could inhibit this enzyme and make this enzyme work less effectively, and thus cyclic GMP sticks around for longer. Okay, so you see how we can either affect it on the production side or on the actual metabolism side. So as an example here, here's a medication called sildenafil. Anyone ever heard of sildenafil before? What is it used for? What's the brand name for it? Anyone know? The little blue pill, Viagra, right? So everyone knows the little blue pill, right? But not a lot of people know it's called sildenafil. Well, sildenafil actually is a phosphodiesterase inhibitor. Okay, so why do you think that would work for? So say you have an older gentleman ready to go out for a night on the weekend, see his significant other, his friend, whoever. Why do you think this would help? Why do you want to affect things like smooth muscle relaxation? Cause vasodilation. What does that do? Increase blood flow. Thus you can develop an erection, right? So you can see here how you can affect the system. So instead of maybe having something that activates guanylyl cyclase, What if I just inhibit the breakdown of cyclic GMP, and thus I have more of it around? That leads to more relaxation, and allows for more blood flow, and thus you have tumesis can occur, right? You can have an erection. Now, actually at work, where I work, Moore's Children's Hospital, actually I give little girls this all the time. And you're like, why would you do that? That sounds very inappropriate and unethical. And I would say, well, how little you know about the effects of sildenafil. Phosphodiesterase is a really important regulator of pulmonary blood flow. So if you have a condition called pulmonary hypertension, I can give sildenafil, and this does the same thing where it will relax those vessels around the pulmonary blood flow and allow for better oxygenation, right? So we do this a lot for kids who have like congenital heart defects, things like that. So if you ever see like a little boy or a little girl on Viagra, that's probably the reason why. It actually has a different brand name for that indication, but that could be the indication there. So you can see there's different ways, and depending on the tissue you're dealing with, you'll get different physiologic effects there, okay? So anyway, so that makes sense? Again, multiple targets depending on kind of what we're shooting for and what kind of effects we're looking for there. Now, you can see here, you can maybe have precursor molecules that will help kind of kick this process off. So nitric oxide is a very important molecule here that can help with this kicking off of the guanylyl cyclase pathway, right? Now, nitric oxide is not the same as nitrous oxide. What does nitrous oxide do? It's laughing gas. I try to get a little bit pumped into the room before class, so that way you guys are a little bit more, my jokes hit a little bit better. But this is nitric oxide, right? So NO actually will cause guanylyl cyclase to activate and lead to vasodilation. So you can start to think about what kind of cases would I want to have vasodilation occur. Well, imagine you have someone who has chest pain, right? Why do people get chest pain? Is it the hot dog eating contest from the 4th of July? Perhaps, or more than likely, it is cardiovascular disease leading to decreased oxygen supply to the heart, usually due to some blocked coronary vessels. Well, if I want to increase that flow of oxygen, what can I do? Well, I can dilate those vessels, right? It causes vasodilation. So by giving a drug called nitroglycerin, people have heard of this before, right? So anytime you have chest pain, they say take your nitroglycerin. It's usually a sublingual tablet or spray. This will get converted to nitric oxide that activates guanylyl cyclase. That leads to smooth muscle relaxation, particularly around those coronary vessels, and thus more oxygen gets delivered. The tissue feels better because now it's not ischemic, and the chest pain goes away, right? Again, what do you think would be a common side effect of, say, someone who is taking, say, nitroglycerin, and maybe they were taking sildenafil as well, right? Too much vasodilation, and then guess what? Hypotensive. Now they're not delivering enough blood flow to the brain, and what happens? You pass out, right? That's actually a really important drug interaction that anytime, say, EMS is responding to a call of someone with chest pain, if it's an older gentleman, you may want to ask, hey, are you taking anything for erectile dysfunction? And if they are, you actually cannot give nitroglycerin because the risk of hypotension is so severe that then you can actually cut off even more flow of blood to the heart and then lead to worsen your problem there, right? So again, these are important things to consider how these drugs will interact with one another through the same sort of pathways here, right? Different mechanisms, but they work very synergistically with one another, okay? And again, why might an older gentleman be having chest pain? If he's physically active, why would he need sildenafil for physical activity? Start to put the two together, right? Anyone with me? No? That's okay. Your guys' minds are pure right now. That's okay. We'll sully that by the end of this class. But again, hard physical activity sometimes leads to chest pain, and you might have taken sildenafil prior to that, right? So that's the thing we're looking for. That's why you ask these sort of questions in terms of what medications they're taking. Anyway, you guys can inform the other people who don't get it yet, but that's all right. So looking at another secondary messenger, it's important here is going to be calcium. Calcium is very, very important, along with this other product called inositol triphosphate, or IP3. Actually, calcium is probably used more widely than cyclic AMP actually is, and it has to do with a lot of things like neurotransmitters, has to do with things like growth factors, hormones. It's the reason why you release insulin from the pancreas is due to influx of calcium, triggering that release of those vesicles there. This helps with muscle contraction, this helps with cell division, all sorts of things. So calcium is super, super important in terms of cell signaling throughout the body. So the way this actually is going to work, and I'll show you a picture that will make this more clear in a second. Usually you're going to find this enzyme called phospholipase C will be membrane bound actually bound within the actual membrane itself of the cell. It will get activated by a G protein typically, right? So that's the receptor part. Now the calcium is coming into play as the secondary messenger here. And basically phospholipase C will form two products here. One's called IP3 and the other one's called DAG, or diacylglycerol. Again, it's not so important to remember the actual full names. I'll probably put the abbreviations along with the full names on there to help with kind of memory purposes if it's on the test. And basically what you're going to find is that this will then lead to release of calcium within the cell. Now, where do we store a lot of calcium within the cell? So sarcoplasmic reticulum in what particular type of cells? That's in the muscle, right? But in other types of cells, where is it kept? It's the endoplasmic reticulum for those, right? They will also help with calcium storage as well. But basically what you see here is once this gets activated, the G protein will lead to phospholipase C to do its thing. You'll find that this will work, diacylglycerol stays within the membrane, but the IP3 actually goes down and will release calcium out of this endoplasmic reticulum and will then cause further cell activity, right? Whether it's releasing insulin or it's causing cell mitosis or whatever the case may be, right? So that's basically how that's going to be working there. So, and just to show you how you can have multiple different pathways all interacting with one another, imagine here we have a vascular smooth muscle cell. You can find there's lots of different receptors that may be responsible for causing either vasoconstriction or relaxation, which is why you have so many different types of medications that can be used for hypertension. You have so many different ways for the body to regulate this. So as an example, you can have adrenergic nerves releasing norepinephrine onto alpha receptors that causes constriction. You could have things like angiotensin II interacting with G proteins to cause further calcium release, which leads to vasoconstriction. There's a lot of interacting pathways here. Some are antagonistic to one another. So as an example, you could have nitric oxide leading to relaxation here. You could have things like gene transcription actually being affected. So lots of different ways to interact with the system. This is what we cover in Pharm 1 and 2, right? We go into great detail on these different pathways and how we can interact with this to lead to whatever effect we're looking for. Because do we always want to lower a patient's blood pressure? Sometimes we want to increase it, right? Sometimes I want to get their blood pressure up if they're septic or whatever the case may be. So it's important to understand how these different processes work, okay? All right, so any questions so far on that? Yes, ma'am?
Just a quick question on the G protein.
Mm-hmm.
Would both the signaling molecule and GTP activated, would both of those be considered a ligand?
In the case of the G protein, so the signaling molecule is the ligand in that case there. In terms of like the cyclic GMP formation, you could maybe say like nitric oxide could be the ligand, okay, right? Because then that will kick off the guanylyl cyclase pathway there. So that could be one way to look at it. Because okay, nitroglycerin basically is going to be a donator of nitric oxide essentially, right? It'll eventually get converted over into that. Any other questions? And feel free to always interrupt me. I have no problem digressing into whatever weird tangent you guys ask me a question on. Some people use that strategically to get me to not cover as much material. Again, sometimes I don't catch on until I'm like 20 minutes into a random diatribe, but sometimes it works, right? Anywho, let's do a 10-minute break. We'll come back and then continue on with our topic. Getting into dose-response relationships. What are we talking about here? Basically, this is trying to determine what dose we give to a patient and what kind of response we're expecting to see out of that patient, right? So, for instance, if I give a little bit of a drug, I should expect to see a little bit of effect. If I give a lot of drug, I should expect a lot of effect. Seems pretty common sense. You may find it gets a little bit more complicated than that as we go through this. So anyway, when we're looking at this, we can look at pharmacodynamic studies looking at varying doses. And again, this is what you would see like in the phase 1, phase 2 sort of trial, right, when you're trying to get a drug to market. They'll look at the effects either in a group of subjects or potentially if they're in like preclinical sort of setting, they could do it on individual cells or tissues or organs, whatever the case may be. And then when we're looking at that response there, we're seeing kind of what kind of drug concentration are we getting at the receptor site, and then what kind of effect should we see from that, right? Because just because I give a drug orally doesn't mean much of that drug may get to the actual receptor site. It just depends on a lot of factors that we already talked about, and we'll get into more detail on that. Remember that first pass effect I talked about? Remember, like the liver will metabolize some drug. So again, depending on a lot of factors that you may find, you may give a lot of drug, but not a lot of it actually gets to that receptor site. Well, let's look at the responses here. So again, looking at the example of lowering blood pressure, right? So if I were to give you 5 milligrams of a drug and I saw a 10 millimeter of mercury drop in your systolic blood pressure, and then I give you 10 milligrams of drug, I should expect to see the same, greater, or less drop in systolic blood pressure. You expect to see greater, right? Again, it seems like really common sense, but it does get a little bit more complicated than that. And essentially, that's just getting more drug to the receptors, right? So the more drug that's available, the more likely they are to bind to that receptor and thus have their mechanism of action have that physiologic effect you're going to see there. And so typically, when they're testing these initially, they're going to try to show 3 things. So for one, if the drug isn't there, you don't get any sort of effect, right? How do you test this sort of thing? Like, how can I test it in individuals and make sure that even though there's no drug there, they don't get any effect? Placebo. So what does placebo do for us? Yeah, lets you know the actual drug is working because, again, mind over matter, right? If I think I'm taking something for my blood pressure and I feel more relaxed because I'm doing something positive for my health, what do you think my blood pressure is going to do? It's probably going to go down, right? Just for example, if I were to give you, say, like a tablet before you walk into your test and I say, this is going to make you 10% smarter, You go, wow, I feel so much more relaxed, I'm that much smarter, and you might do better on your test. That is placebo effect, right? Unless I were to give you like an Adderall, and then you might actually do better, but hard to say. Or worse, actually, I have no idea. Anyway, point being though is that we want to show that when the drug isn't there, you shouldn't see any sort of effect. And then by adding more drug, you should get more effect. Now, is this going to be something that happens sort of ad infinitum? No, there's always going to be a plateau, right? There's always going to be a point where even though I'm adding on more drug, I should not expect to see more effect, okay? When do you think that occurs? All the receptors are being bound up, right? So they're all kind of full up. They say, we have no more room for any more drug. We're not going to get any more effect out of this, okay? And then they should be able to show them when taking the drug away, you should get back down to baseline, right? So again, if I were to give you an antihypertensive, blood pressure lowers and I take that away, you should expect to see the blood pressure to come right back up, right? So they should be able to show that when you're giving these drugs here. And typically what you find is this sort of S-shaped kind of curve here. And so you're going to find that typically on the y-axis, you're going to have the response you're expecting to see. So this may be a reduction in systolic blood pressure. This could be heart rate. This could be anything you decide to be your response. And then the dose is going to be on the x-axis here, right? So increasing dose is the further you go to the right. And so again, you're going to expect to see this curve here. We're going to find you get increasing effect to a point, and then when you plateau out, that is when all those receptors are essentially being bound up. Adding more drug does not lead to any more effect, but what could it lead to? More side effects, right? More adverse effects you can see by just adding more and more drug there, right? So there's always going to be a limited benefit to going up, and that's why if you see like, hey, there's a max dose on this drug, usually it's because of that sort of thing there, right? Because it's saying, well, you're not really going to get much more effect, however, you're going to see more side effects, right? So you're taking, say, for instance, ibuprofen, they say don't take more than 800 milligrams. It's because they really have shown that there's not much extra benefit, and you only get more side effects there, okay? Now, as I mentioned here, here's what our axes are going to be. The y-axis can really be anything, right? This could be enzyme activity, this could be membrane potential, whatever the researchers are actually setting up to be there. But that's what we're potentially looking for in terms of what kind of clinical response you're seeing there. Now, some of the definitions we're going to look at when comparing curves, because we can actually compare the different curves of different medications to kind of glean some information from them. So for instance, one of the important definitions here to know is the ED50. This means the median effective dose, or the dose of which 50% of the population that you gave that drug to manifest a given effect, right? So if I were to give, say I were to start pumping nitrous oxide in the room, and I got to the point where 50% of you, 32 of you started laughing, that may be my ED50 for nitrous oxide, right? Am I going to do that? Probably not. Who knows? But you can see that's the ED50, right? So where 50% of people actually get that response. Now, do you think we dose drugs here at the ED50? Probably not, right? I don't want to give a drug to a patient and say, there's a 50% chance you're actually going to have the beneficial effect I'm looking for. You think the patient's going to be like, no thanks, bud. I'm good. Like, they probably want it closer to like 100%, right? So you may be dosing actually much closer to the kind of maximum therapeutic effect, but the point being is that we can compare different drugs together by comparing their ED50s, and so that's going to be really important, as we'll show you in just a few minutes here. Now, the shape of the curve can be plotted a couple different ways. Usually you're going to see that we do it on a semi-logarithmic curve. This is nice because we can compare vastly different doses of medication there along the same x-axis. So for instance, if I'm comparing two medications, one of them is dosed in micrograms versus milligrams, I can have a really, really long curve to do that, or by using the log of the curve, it gets a little bit more easier to look at. So that's why you typically see that. Not super important for you to memorize that point there. Anywho, but again, it's really easy to estimate the ED50s and then compare these between different medications here, right? So that's why we use that log of the curve. That's why it's usually semi-logarithmic. Now, 4 points to note about the drug curves here. You're going to find that the baseline response should be the bottom, should be when you have zero drug around, you should be getting zero effect, right? The top of the curve, this is also known as the Emax. This is where you get that plateau effect, right? What is the maximum effect you should expect to see out of that medication there, okay? Now, if I have two antihypertensives, do you think they'll have the same Emax? Not necessarily, right? You could have one drug just be objectively more effective than another one, right? That's okay. We'll talk about that comparison in just a few minutes here. The ED50, as we mentioned, is where you're getting 50% of that effect. And then the slope of the curve is also going to be important here as well. Anyone want to venture to guess what the slope kind of tells us? You can have shallow curves. You could have steep curves. What the difference is?
How much you have to increase the dosage to get like more effect?
Essentially, yeah. So it's kind of our delta, right? So if I increase the dose by 1 milligram, do I expect to see a little bit of change in effect, or do I see a lot of change in the effect? The steeper the curve, the more delta you're going to see there, the bigger change you're going to get for small increments in doses, right? So again, you may dose a drug as, okay, I can go from 0.1 to 0.2 milligrams, or for some drugs, you may say go from 0.1 to 1 milligram, okay? A lot of it has to do with the steepness of that curve there, and again, it's just another point that we can look at to try to compare these together. Now, if you were to look up in a drug reference, do you think you're going to find a lot of these curves there? No. And I don't necessarily want you to think about these when you're prescribing drugs in the future, but start to internalize some of these factors here, and this goes into why we dose drugs the way we do, and why certain drugs are dosed in milligrams, some are dosed in grams, some in micrograms, by doing these kind of comparisons here. Okay, so this will become more clear in just a few minutes. So there's a couple ways we can do this. There's two varieties of curves. One's a graded response, one's a quantal response, right? So graded responses are better when you're looking at the effects of a drug in an individual, either in a particular tissue or a particular person. The quantal response we're going to talk about a little bit later is going to be kind of the effects on a population, right? So that example I mentioned where I'm pumping in gas to see when 50% of you fall asleep, that's a quantal response, okay? We'll get into what that means in just a few minutes. Talking about the graded response here, this is going to give you a better example of sort of what it looks like when you're looking at this equation between the drug and receptor versus the actual complex between the two. Remember, if I try to increase one of these components here on this side of the equation, where's it going to drive it? To the right, just like any kind of chemical equation there. So I can't really affect the number of receptors a person's expressing, but I certainly can affect the dose of drug that we give. So by giving a bit more drug, I'm more likely to get more of this receptor complex. That means it's actually interacting with the receptor. You're expecting to see some sort of clinical response, okay? And then when all these are bound up, what do you call that? It's your Emax, right? That's the peak of the curve, the plateau of the curve you're going to be getting there, okay? And so again, this is good when you're having things like I want to look at different gradations in response, right? I want to see how many millimeters specifically of mercury difference I get in blood pressure by increasing the dose of this medication there, right? So that's how we kind of will use these usually for continuous sort of responses, okay? Not a yes, no, all or none sort of phenomenon, but something that's more continuous, right? So again, the response can be anything that has continuous and gradual. So heart rate's a good example of this. You can look at enzyme activity, anything that's going to be on this sort of graded sort of response there. The quantal response, so that's an all or none phenomenon. We'll talk about that a little bit later on, okay? So getting into this, you're going to find, again, as I mentioned before, that these graded response curves really show you that factor of receptor occupancy, right? So the more occupied the receptors are, the more effects you're going to get. When they're all occupied, that's 100% effect. You're not going to get any more benefit by giving more drug. That's why you see that plateau there. And again, this will be important when we're starting to look at things like mixing agonists versus antagonists, and we'll get into more details on that in just a little bit. But presumably, when you're at the ED50, what percentage of those receptors are being occupied? Roughly 50%, right? So you guys are already catching on. Now, when we're looking at this, we can also look at in terms of the potency of the drug and the efficacy. Now, when I say potency, what does that mean? How much drug I need to get a given effect, right? So a very potent drug, do I need a little bit or a lot of it? Just a little bit, right? If I have a very not very potent drug, you need a lot of it to get the same sort of effect, right? We'll talk about equal potency in just a few minutes here when you're comparing these drugs together. Efficacy is going to be determined based on that max effect, right? Where is that plateau actually going to be? How high is that plateau going to be there? Now, clinically, what do you think you as a clinician are going to care about? Potency or efficacy? You're probably going to care about efficacy, how good your drugs are actually going to work for a patient, because the people that are doing these studies have already figured out the dosing, right? They've already figured out the potencies of it. So when you look in the drug reference and you see that, hey, 5 milligrams of morphine is roughly equivalent to, say, 50 micrograms of fentanyl, that's what they've already kind of figured out, right? You just care about how effective that drug is going to be for that patient, right? Because you want to deal with that pain, right? So, for instance, we just started up a new residency program over at Nemours. Does anyone know what the most dangerous day to be in a hospital is? It's like July 1st and all the residents start up, right? Very dangerous. Now you have like brand new doctors and people that are working for the first time. They have no idea what they're really doing. Right? Very dangerous, okay? So we have to watch all of our orders like hawks because we have to make sure nothing crazy is going on. But we had a kid who had sickle cell disease who was coming into the ER, and he had a resident who's down there who was working. And anyone know about sickle cell disease patients is that they have a lot of, they'll come into the ER for acute pain crisis, right? And they have a lot of pain issues that happen when they have their cells start to sickle up, and they very, very painful. They're oftentimes on a lot of narcotics as well, things like opioids, like oxycodone and whatnot. So anyway, so I see this order come across, and I recognize the patient's name because I've seen him a lot. He's a sickler, right? So, and it came across with 1 milligram of morphine. And I was like, 1 milligram of morphine, that's like homeopathic dosing for this kind of kid there, right? Because I knew that was not going to be effective for that particular patient, right? So I had to call it down. I was like, hey, this guy's usually on a lot more than this. Usually he's taking, at least 4, maybe 5 milligrams. Oh, wow, I didn't realize that. So clinically, you care about the efficacy of the drug itself, right? The potency we've already kind of taken care of when you're actually doing ordering in milligrams or grams, whatever the case may be, okay? So again, these are things you'll be taking into account when you're actually dealing with real people, okay? Anyway, so again, as I mentioned, the potency there is going to be usually in terms of milligrams, but could be micrograms, nanograms, could be in units. If you ever see like IU, anyone know what IU means in terms of drug dosing? International units. Now, there's no domestic units, but I usually just call them units, right? So usually we'll see that. But it could really be anything, okay? Again, looking at this, how much do you actually need to cause the pain relief you're looking for? Maybe the drop in blood pressure, heart rate, whatever the case may be, okay? And again, how effective it is overall is going to be the efficacy we've already talked about. So if you were to look at these different doses here, or these different drugs, so we have drug A, drug B, and drug C, notice here, in terms of efficacy, are any one of these better than the others? No, they all have the same Emax, so you say these are all equally efficacious. However, what do you think would differ in terms of looking up the dosing for these drugs here? The potency, right? So this would mean that any of these would be perfectly fine for a patient, say if I needed to treat pain, but I would have to figure out what kind of potency we're dealing with. So as an example, say for instance, you have a drug that is, say we got morphine over here, we have something called Dilaudid. Anyone ever heard of Dilaudid before? Hydromorphone's a generic name for that one. And then we have, say, fentanyl over here. Any of those opioids can be equally efficacious for treating a patient's pain, but in terms of the dose is what's going to matter here. So in terms of fentanyl being A over here, it's going to be the most potent because I need the least amount of drug to get the effect I'm looking for. So as I mentioned, like 50 micrograms could be enough to get the pain relief for that patient there. I was just mentioning, okay? Maybe 100 micrograms because he's pretty tolerant to that stuff. So 50 to 100. For Dilaudid or hydromorphone, I may need, say, half a milligram or 1 milligram. In order to get the effects I'm looking for. So you'd say this is kind of middle of the road in terms of potency. The least potent would be morphine, where I need like 5 milligrams. Okay. So again, even though those are all equal potent doses, because they all get the same efficacy out of it, the doses is changing there. So I would say that is equal potent between the two there. So 50 micrograms, say, to 4 milligrams of morphine. Okay. And so those conversions are important because, say, for instance, a patient's coming in on one medication. You don't have that at the hospital. You have to convert them over to something else. You need to know what the equal potent dose for that new medication is. Because otherwise, if you overshoot it or undershoot it, you can cause some significant problems for those patients there. That makes sense so far? So again, in terms of how potent drug is, the further to the left it is, means the less drug I need in order to get that effect. That is the most potent out of the bunch. So A would be the most potent drug here. C would be the least potent. And you're doing this by comparing the ED50s to one another. That's why we mentioned the ED50 so much. Not because it's important for our dosing, but because it is important for comparisons between these three here. So again, looking at these, if you were to look at the rank order of potency between A, B, C, and D, you'd say which one is most potent? A, and which one would you say would be least potent? D would be least potent here, right? Because you're looking at the actual ED50s, where they're at, you see D is going to be furthest to the right, so you need the biggest dose in order to get the effect you're looking for, right, to hit that ED50. Okay? Again, this is not to do with efficacy right now. We're just talking about the potency of the drug. So looking at efficacy, as I mentioned, the ability for that drug to have an effect here. So looking at these, which do you think would be the most effective drugs? Yeah, A and C would actually be equally efficacious. Now, say for instance, we're going back to our pain example. Say you have like fentanyl here, you have Dilaudid here, and now down here you have like ibuprofen and Tylenol. Now, it doesn't matter how much Tylenol I give to somebody. Am I ever going to get the same kind of analgesic effect as I am out of morphine? Never in a million years, right? I probably killed the patient with hepatic failure before they ever have that kind of analgesia. I guess at that point they're not feeling any pain. They're dead, so there you go. But anyway, not ever going to be as efficacious. So that's why you find that the plateau of the curve is much lower than some of these other medications here, right? Now, B and D you could consider to be equally efficacious, but they're not equally efficacious to A and C. Okay. Now, again, which one would be the most potent out of the bunch here? Probably A and B. If you actually looked at the ED50s, it'd probably be pretty close to one another. So these will be equally potent to one another, right? So you need roughly similar doses of the drug to get the maximum effect, but you're always going to find A is going to outwork drug B in that case every single time, right? Just because it has more maximal efficacy. Now, does that mean I would never use drug B? Not necessarily, right? So for instance, maybe I just don't need all that efficacy, right? If I have a patient who comes in and say they have an abrasion, not that painful, right? I probably don't need to hit them with some morphine, right? Versus if they have their femur sticking out of the leg, they probably need something a little bit stronger. That's okay. Maybe drug B gets the job done and is cheaper. Could be another reason to use it too, right? So a lot of considerations go into it, but again, at a baseline, it's important to understand kind of which ones are most efficacious, least efficacious, more, less potent, because you might have a graph on the test or something, you'd be able to make some inferences based on the curves there and actually comparing them. Okay. So, and again, the higher that curve goes, the higher that plateau is, the higher the Emax, the more efficacious the drug is going to be. And clinically, you care more about efficaciousness or efficacy than you do the actual potency of the drug. And again, looking at this, which ones would be the most efficacious? Probably A and C. Looks like C might be edging out a little bit, but A and C typically, B would be kind of in the middle of the pack, and D would be the least efficacious out of the bunch. Okay. Okay. Everyone with me so far? So that's kind of the basics of dose-response relationships. The next thing to consider is going to be affinity and then intrinsic activity. So what does affinity mean? I like to think about how tight does it like to hug that receptor, right? So like how friendly. So if you have like somebody that is like a really high affinity to you, they're probably going to like hover in your personal space all the time. You can't get rid of them. You're like, just go. They won't. Like sometimes my kids have a really high affinity for me. Sometimes they don't. It just depends. So essentially, this is how tightly the drug likes to bind to the receptor. Okay, so things with high affinity like to bind very tightly. You may actually not need a whole lot of drug in order to get the effect you're looking for. Sometimes drugs have very low affinity. I actually need to have much higher concentrations to get the drug I'm looking for. So affinity can have a big impact on the potency of the drug as well, as we'll see in just a few minutes here. Anyway, so again, affinity is how tightly it's going to bind to that. And then you're going to find that intrinsic activity is basically how much it actually activates or maybe doesn't activate the receptor, as you'll see there. Because remember, we talked about agonists. Agonists do what at the receptor? They activate it. What does an antagonist do? Blocks it. It keeps it from being activated, right? So again, that's going to be important. We're comparing efficacy in terms of affinity and also the intrinsic activity here in just a few minutes. Okay. So, as I mentioned, intrinsic activity, just that ability once it's bound to either cause the effect you're looking for or potentially block it, right? So again, you usually don't have negative intrinsic activity. It's a very rare case you would ever have that. Generally, it's either 0 or something above that, as we'll see. And that can lead to cases where, yeah, I can have something that 100% activates a receptor. I can have something that completely blocks the receptor. Is there anything in between? Yeah, that's where we get into things like partial agonists, so things that have partial effects at that receptor there, right? Now, in terms of efficacy, which ones do you think would be the most efficacious at causing that effect there at the receptor? A full agonist, right? Partial are never going to have the same sort of efficacy. And then obviously the antagonist would never have any efficacy. Okay, I'll show you some cases where that's actually important clinically and where we actually are looking for some of those very particular sort of effects there. So again, so moving on, so I'll show you that in a few minutes, but looking at the actual quantal dose-response relationship. So moving on from the graded, which again is going to be kind of on a scale, things like actual millimeters of mercury of blood pressure or pain scale or things like that. Now we're getting to the quantal dose-response relationship here, right? So this is actually showing basically in a population. So say I had 64 willing participants in a study, right? I'm just kidding, I can't do studies on these, not ethical, not after last time. And so essentially, it's looking at, say, the all or none response here. So the good example I like to use here is going to be, say, you're going for surgery. Now, every drug is going to have an ED50 in terms of this quantal response here. So when you're going for surgery and the anesthesiologist is putting the mask on you, presumably, would you like to be awake for your surgery or asleep? I assume you want to be asleep, right? No one wants to be awake for whatever kind of procedure they're getting there. And so in this case here, if I were doing like an anesthesia study, I would say the ED50 is when the 50% of the population that I'm testing it in fell asleep, or say 32 of you fell asleep in this room. Actually, I do that sometimes in my lectures. I like to see like what's the ED50. It's usually about an hour and a half or so, and then it's a steep decline after that, and then everyone's asleep. But especially the 4-hour lectures, those are bad. But anywho, but again, it's an all or none sort of phenomenon. You can do this alive, dead. You could do this in terms of did they reach a certain threshold in blood pressure drops? Did they hit a 10 millimeter mercury drop in systolic pressure or not? So it's an all or none sort of phenomenon. It's a very dichotomous sort of thing here. And again, it's where 50% of the people either meet the response or they don't meet the response. And so, again, we mentioned with the ED50 there, here is now incorporating into this are also going to be what we call LD50s and TD50s. TD50 just means toxic dose 50%, right? So this means that what is the median effective dose in order to elicit a certain toxic effect out of a group of patients, right? So again, what do you think might be a side effect from, say, a sedative medication? I'm trying to put you to sleep. What could be like a really bad side effect? Maybe you stop breathing, right? Respiratory depression. So that could be a TD50. I could figure out, okay, when do I actually start to see respiratory depression in patients when I'm giving them this medication, okay? Could be one thing. And then you have your LD50, which is what? You would actually kill 50% of your patients. Now, do we actually clinically figure out what the LD50 is when they're doing drug studies? Presumably, no. We don't like to kill patients unless we really just don't like them, right? Just kidding. Do no harm, right? Anyway, but in animal studies and things like that, they will figure out things like the LD50. Or if we have like kind of anecdotal evidence, sometimes we'll try to put together what an actual LD50 is. But basically, by comparing this, we can start to consider drug safety. So presumably, ED50s will tell us how effective a drug is, but do you think you want a drug to have a really high LD50 or really low LD50? Presumably really high. I want it to have a lot. I want it to take a really, really large amount of drug to cause someone to die, because that gives me a much wider margin for error. Okay. There's some medications where if I have a 10-fold dosing error, the patient's going to be just fine. There's some other drugs where if I do a 10-fold dosing error, that patient will be dead. So that when we start to talk about the margin of efficacy or the margin of safety, this is what we're talking about, is starting to compare things like the TD50 and the LD50 to our ED50. Okay, so I'll show you some examples of what that looks like in a second. So, and you can actually graph all three of these on the same curve here, and ideally you want as much space between the ED50 to both TD and LD50s here, right? But again, we use the 50% mark because that is good for comparison purposes, right? I can compare two drugs here together to say, well, how do LD50s stack up between one another? Obviously, the one with the lower LD50 probably is the more dangerous drug, quote unquote, right? So we call this the therapeutic index, is that ratio between either the LD or the TD50 to the ED50. You can see it being calculated here, where the ED50 will be in the denominator. The TD or the LD50 is going to be in the numerator, okay? So the higher that ratio is, the safer, the more dangerous the drug is. The safer it is, right? Because that means the LD50 or the TD50 is out the door versus if it's like right here, right, compared to my ED50, okay? So typically you want a higher ratio, because that means you have a safer drug. And I'll give you some clinical examples in just a second here. But we call that the therapeutic index, right? That's our window of safety to say, well, how close are we? Now, again, every drug has side effects, right? So in some cases, there may be very close overlap between the ED50 and the TD50, because I'm setting what that is, right? I'm calling the side effect whatever I want to be the TD50 there. And the LD50 is kind of well set, right? Are they alive or dead? But the TD50 can really be anything. It could be low blood pressure, it could be GERD symptoms, it could be anything. Okay, so anyway, so the therapeutic index is that ratio between the LD or the TD50 and the ED50. So the larger the distance here, the safer that drug's going to be. Because if you're looking at this, say imagine I'm having morphine here, I'm giving the dose of the drug, ED50 is roughly here. But if I'm at this point on the curve, I shouldn't have a whole lot of people who are having a lot of side effects here. But however, if I keep driving up the dose here, say I'm at the end of this point in the plateau, what am I starting to notice? More people are starting to develop that side effect. And again, as I keep driving the dose up, even though I'm not really getting much more efficacy, I'm starting to get more and more people are starting to develop that side effect. And then again, depending on where the LD50 is, I might start to encompass some of those people as well. Okay, so the wider that is, the safer that drug is going to be typically. Again, here's the actual how you would calculate the therapeutic index here. And again, you can then compare therapeutic indices between two different drugs and actually determine which one's safer. And I'll probably actually put a test question on the test there. And I'll give you the LD50s and the ED50s, and I'll say which one of these you think is the safest drug, or I'll say which one of these is the most dangerous drug. Okay, and so by looking at the numbers, you'll be able to figure it out. Now again, the math I'll have you do on here is not intent. I like whenever I say like this is going to be on the test, everyone's like. But the math I'm going to be doing here, if you can multiply or divide by tens, hundreds, anything with a zero, you're going to be okay, right? It's nothing too intensive in terms of math here. The concepts are what I want you to get, okay? You will not need a calculator. Abacuses are allowed. Just kidding, don't bring an abacus. You'll be kicked out of that room if you do. But again, the math is pretty easy here. But it's important to understand the concepts and able to determine, okay, what goes in the denominator, what goes in the numerator. So they mentioned, again, that the ratio, the larger the ratio is, the better off we are. Now, we can have a group of drugs that have a narrow therapeutic index. And that means they're just drugs that we know that the overlap there between toxic doses and effective doses tend to overlap pretty closely. And we know that we have to do extra monitoring for those patients there, right? So as an example, we mentioned the drug warfarin. You want to remember what that drug does? Coumadin's a brand name? It's an anticoagulant, right? We use it for people who have AFib, we want to prevent clots in, okay? So it's an anticoagulant, so it prevents clots. That's the efficacious, that's the efficacy of the drug. What do you think the big side effect I worry about is? You bleed, right? If I anticoagulate you too much, you get bleeding there. So that means that you're riding a very narrow line between getting efficacious or getting the efficacy you're looking for with no clots versus the bleeding risk over in there. So again, those lines match up pretty close to one another, which means I have to do extra monitoring. I have to monitor things like your PT-INR to make sure you're not too low to where you're at risk for getting a clot, and make sure you're not too high where you're at risk for bleeding. I want to make sure you're right in that Goldilocks zone, right? It's just the right amount of drug in order to get the effect that you're really looking for, right? So to give you an example, comparing different drugs with different therapeutic indexes here, you can see here that for something like digoxin, which we mentioned before being a heart medication, right? It treats arrhythmias, but one of the things you'll learn about when we get into talking about anti-arrhythmic drugs is that anything that can treat an arrhythmia can also cause an arrhythmia itself, right? So again, a lot of these drugs tend to be double-edged swords where they can cause the same problems that they're being used to treat, because they're modifying things like sodium channels and potassium channels, all kinds of stuff. But you can see here that it has a therapeutic index of roughly 2 to 3. That means I don't have a whole lot of margin for error here. If I drive my dose up too much, I can run into issues where I can see a lot of that toxicity start to manifest. Versus something like diazepam or Valium, it's relatively safe, right? You have a therapeutic index of roughly 100, which means that somebody could take 2 or 3 times the normal amount. They probably won't die from it, right? They'll be relatively safe. I care about this a lot because in terms of toxicology, the medication we use nowadays tend to be a little bit safer in some respects than some of the older ones. So has anyone ever heard of a tricyclic antidepressant or TCA? These are old school antidepressant medications, but one of the things you'll learn about antidepressants is a lot of them carry black box warnings. Anyone know what that black box warning is? Increased risk of suicide. And you're like, wait a second, I'm giving this to depress people, but it causes suicide? Really, it's kind of oxymoronic, but it's a risk we know about. So you give people a TCA that had a very narrow therapeutic index, and they would invariably tend to overdose on it. Not everyone, a small subset of them. And they would show up to the ER, and they were pretty close to being on death's doorstep. And if you did not treat it effectively or in time, or they were very late in presentation there. Nowadays, though, we have things like SSRIs or like Zoloft or your Paxils and things like that. Therapeutic index is huge. I can have people take handfuls and handfuls and handfuls of the stuff and really not manifest all that much toxicity, which is good. It has a much wider therapeutic index, which means that I don't have to worry about someone overdoses on that drug so much as I do if they do on a TCA. Oftentimes I talk about my sphincter tone in terms of like responses to things, and so the higher the sphincter tone, the more worried I am about somebody. So if I have like a TCA overdose coming to the ER, my sphincter tone is usually like 11 or 12. If it's like an SSRI overdose, I'm like, it's like a 2 or 3. They'll be fine, right? I'm not that flippant about it. But I'm like, okay, well I can at least set my internal worry gauge more accordingly based on the therapeutic indexes of those drugs there. Okay. Now, as I mentioned, with narrow therapeutic index drugs, we typically have to do more monitoring, which we can do things like monitoring blood levels. By actually looking at the level of drug in the blood, that tells us kind of, we usually have an established therapeutic range to show if you're too high, if you're above this, you're going to see toxicity. If you're below this, you're not going to be having much efficacy. And so we can monitor that. Sometimes we're using surrogate markers, like I mentioned with warfarin. We measure PT-INR, which is a measure of your blood's ability to coagulate appropriately. So that's called therapeutic drug monitoring, right? That's a process of actually measuring levels of things or measuring the labs in order to determine, are we at the right dose for this patient? Okay. We have a whole section on that later on. We'll get into that in a bit. So just to give you some examples of narrow therapeutic index drugs, you can see here, kind of the target levels we're shooting for with some of these medications. And again, don't memorize this list. We'll cover these in much more greater detail in the upcoming semesters, but just to kind of give you an idea. Things like, let's see, something you might have heard of before. How about lithium carbonate? Anyone know what this is used for? Bipolar disorder, absolutely. Anyone know where you used to find this in a popular soft drink? 7-Up used to be lithiated. Yeah, I used to have cocaine and Coca-Cola, and we had lithium in 7-Up. That's why people who drank it had such good moods, because they're on lithium, right? Anyway, but you can find here it's a very narrow therapeutic index, right? So between 0.6 to 1.2 milliequivalents per liter. If someone takes too much or too little, you can start to see how they get outside of this range pretty easily. Things like digoxin, as I mentioned, very narrow therapeutic range, 0.8 to 2 nanograms per ml. It does not take much of this drug to get outside of that range and cause problems. So this is why we do blood level monitoring, to make sure that they're at the right range where they get the efficacy you're looking for, but hopefully not too much toxicity. And again, to give you a pictorial example here, if I have someone who was taking warfarin, you'll see here this is a much more narrow therapeutic index than someone who's taking something like penicillin. What do you use penicillin for for infections, right? So again, I can have someone who takes a ton of penicillin and not really have too much of an issue with it because penicillin tends to be more specific for affecting bacterial cells than it does human cells. That's why we like it as an antibiotic versus warfarin affects our body pretty specifically. You're going to find it has a much more narrow therapeutic index there, okay? So again, just know that wider the index, the safer that drug typically is overall. So again, looking at these curves here, it's important to kind of understand the difference between the quantile versus the graded dose response curves. Again, why we look at so many logarithmic points there, so that way we can compare a lot of different doses together, things like that. And again, understand like why we actually look at these. Like clinically, you're never going to be looking at these curves here, but when you look up your drug references and they're giving you different doses, that's already been figured out, right? They're telling you what the equally efficacious doses are. They're telling you the doses for a specific indication based off of studies like this, okay? Okay, so why do you think people have different variations in drug response? I can give the same dose of a drug to two different people, they're roughly the same size, and I get wildly different responses. What do you think that is? Some people are more sensitive, metabolize, that's a good point. So some people metabolize drugs differently. The amount of receptors being expressed, absolutely. All of these will go into it, right? So again, I wish there was one answer I could tell you, but honestly, it becomes very complicated pretty quickly. And so the response you can see with some people tends to vary quite considerably, right? I hate to say it, but like, not in a derogatory sense, but in some cases, all your patients tend to be a little bit like snowflakes, right? They tend to respond a little differently than one another in some cases there. So by seeing and giving a lot of people the same drug, you kind of learn those little variations there. You kind of learn how people respond differently depending on different factors. And we'll look at some of these in more detail here in a second. So some of the variation responses we'll talk about include things like idiosyncratic responses. We'll talk about tolerance and tachyphylaxis, and then hypo and hyperreactive responses you can see with medications. Now, idiosyncratic responses, what do you think this means?
Like idiosyncrasy.
Idiosyncrasy, what does that mean?
It's like a unique individual trait.
Yeah, it's just like a random sort of thing. Like you can't predict who's going to have one of these responses here, right? It's not really an allergic response. It's really just kind of like some people are just going to have this reaction, and it's really difficult to guess who's going to have that reaction, right? Because again, we don't test for every single genetic polymorphism out there. We don't check for every single thing that could go wrong, and because of that, sometimes you're going to get surprised a little bit. And it really cannot be explained by the pharmacologic mechanism of the drug. So for instance, with warfarin being an anticoagulant, if someone comes in bleeding, I'm not going to go, well, I wonder why they're bleeding. No, I'm going to say, well, yeah, that's the drug working. Like if that's its intended effect, it's just got too much of it around. Versus someone comes in with warfarin and they're having some really oddball side effect, I might be like, well, that doesn't really jive with the mechanism. Something else is going on here, okay? And so again, this is not really an allergic response, and it cannot be produced reliably in other individuals. Probably could be in that one particular patient, but not in other people you give it to. So again, very rare when these occur, difficult to predict. And again, it may or may not be dose dependent. Some people may get it at very low doses. Some people may get it at very high doses and everything in between. So that's why it is so difficult. Most of the time, it has to do with the genetic predisposition, right? So they have either some sort of polymorphism or they have some kind of, sort of ethnically related mutation or something that leads them to have that particular reaction. So as an example, has anyone ever heard of a G6PD deficiency? So something that comes up every once in a while. Oftentimes patients may have it. You don't even know about it in a lot of cases unless you have some sort of trigger come along and actually demonstrate it. But it's very important because there's, for instance, a drug, it's kind of old school drug called Primaquine. It's a anti-malarial. And it can actually, if you give it to somebody who has a G6PD deficiency, it can lead to hemolysis of the blood cells. Oops, like you don't want to cause that in your patients, right? That's not the point. But again, unless you test every single patient for G6PD deficiency you give that drug to, you're not going to know about it, right? Some people have that history already, so you already know about it beforehand, which is something you want to take into account, but a lot of times you don't know that. Again, I could test every single patient. What's the drawback of doing that? It's pretty expensive, right? And again, we don't have a nice quick assay just to test it very easily and cheaply. So because of that, we don't test it unless we have a really high risk sort of patient, maybe a family history, or we know they have a bad reaction to medications before, things that may trigger us to think, hey, maybe there is a G6PD deficiency here. So, but a lot of times we'll have patients who, when they do come in and we have that history, that is very important. We take that into account, saying, okay, well, I know they have this now. Now I know that there's a whole list of medications they cannot get because it will trigger this. Instead, I have alternatives I can recommend instead, right? So these are important things to factor in if you know about it in these patients here, that we don't trigger it over again. Now, people can have a hypo or hyper-reactive response to medications here. So a really good example of this is Benadryl. So most people have probably taken Benadryl or something similar at some point in their life, usually for allergies or something. And usually, what is the main side effect of it? You get a little sleepy, right? So Maybe you use that for its therapeutic effect, right? So for instance, anyone ever heard of the drug called Unisom? It's over the counter, but it's actually in the same class as Benadryl. So people will take it for sleep. They're using a side effect for therapeutic effect, right? Well, in some people, they get what we call a paradoxical reaction. We see this a lot in kids, and certain adults will also have this reaction as well, where they will instead get extremely excited. They'll be bouncing off the walls, tearing down stuff. They go absolutely insane. Is it easy to predict who's going to get that? Unfortunately, no. So again, I was very scared the first time I ever gave my kids Benadryl. I was like, listen, you kids, you just need to go to sleep. This postnasal drip you got going on is causing you to wake up coughing and you're throwing up. Like, I just need to get this kid to sleep, right? And so that was going to be useful for that because it helps dry them up and all that, right? But I was really worried that first time. I was like, if I give this to them and they're up until 3 o'clock in the morning, things are not going to be great. Fortunately, they were at a typical response, but there's a very good chance that they could have been one of those kind of hyperreactive responders, and they could have been very excited by that. So again, difficult to know, but if you can predict it beforehand, or if you at least know about it beforehand, it's good to be able to react appropriately. Another thing could be with, say for instance, opioid pain medications. So has anyone ever heard of the drug codeine before? Or Tylenol number 3. So codeine's a pretty wimpy sort of opioid, but what it does in the body actually gets converted over into morphine. Now, some people express a lot of the enzyme, and it's that CYP2D6 enzyme that converts that over. They do it very easily. They convert a lot of it over into morphine. So presumably they get a lot of therapeutic effect from it, right? That's good. Some people are very poor metabolizers, and they don't convert a lot of it over. So those people, what do you think they get out of it? Not a whole lot, right? So again, some people are going to be like, I tried that stuff, it didn't really work for me. They could be poor metabolizers, right? Because some people are like, yeah, that stuff is great. They're probably good metabolizers, right? They can convert a lot of it over to morphine. Well, we had some cases here. We do not use this in pediatrics anymore because we had some kids who were getting tonsillectomies. They had obstructive sleep apnea, right? So they had big and large tonsils that were obstructing their airway, so they have a lot of snoring and issues sleeping. And so we go and we cut them out, right? And what do you think happens to that tissue after surgery? It's irritated, it's inflamed, it swells up, right? So you'd have the swelling that was happening. We knew about that, right? So we knew that's why you get to eat a lot of ice cream after you have your tonsils out, right? Because all that swelling that happens there, right? So you give something cold to try to get that down. Well, we would give codeine to these kids in order to help with the pain relief. Well, certain people tend to have a lot of the CYP2D6, and they convert a ton of this stuff over. And one of the big side effects of opioids that we worry about that can cause death is respiratory depression. So imagine you have someone who has a big and large airway now, a little more edematous because of surgery, and now they have this thing is impeding their respiratory drive. Guess what happened? They stopped breathing and they died, right? Usually overnight. So because of that, we said, well, we can't predict who all is going to have this metabolite or the polymorphism. So because of that, we're just not going to use it at all, right? We have other drugs that work much better. We're just going to stick with those. And so that's what actually led to a complete formulary change in a whole subset of population that we just don't use this drug anymore. So again, these are important things to consider when they become important for the type of patients you're taking care of. Does that make sense? Okay. Anyway, so what is tolerance? I try to be very tolerant of my students, especially when they say, oh my gosh, I'm late for class. Well, in terms of drugs, what does that mean?
Like how much you can take till you see an effect?
You sort of, yeah. So it's kind of like, for instance, now again, I know none of you ever participated in this, but some people, when they go to college for the first time, they like to drink underage, right? Now, those people we call alcohol naive patients, right? Now, those people, if they have a shot or two, do they get a lot of effect or just a little bit of an effect? So college freshmen, they tend to overdrink pretty easily. Just a little bit of alcohol goes a long way for them, right? They have not built up tolerance. Now, by the time you're a college senior, you're a seasoned veteran, right? You can handle quite a bit of alcohol. That is tolerance that is developed over time because you're chronically challenging the body to the substance, and the body gets used to that effect, right? That's your new normal, essentially. And so you can have patients, and anyone know what like the legal limit in terms of alcohol levels in the blood? Like 0.08 or 80, depending on the units you're looking at. But you can have patients who have a level of, say, 100, 200, 300 or 400, and they're talking to you like I am right now. I'm at about a 100 right now, so... but I have some I'm just kidding. No. But you have patients who are like literally they're like 300 or 400 alcohol level, and they're just totally normal because they've developed a significant amount of tolerance to that, right? Or for instance, if you have like elderly patients, you could have these grandmas that are like 90 years old who are like 100 pounds sopping wet, and they're on doses of morphine that if someone who had never taken morphine before took it, they would be dead. because they've developed a lot of tolerance over time. They've worked their ways up to those sorts of doses there. Okay, so tolerance is that effect where you kind of get used to it over time. The body maintains that as a new normal sort of homeostasis. That also means that what happens if I take that drug away all of a sudden? Undergo what we call withdrawal, right? So for instance, have you ever seen someone who has had their opioids taken away from them and they're chronically on them? They have pretty significant withdrawal effects, right? Their GI tract wakes up and they're usually vomiting or diarrhea. They're very diaphoretic. They're very cranky. They feel very miserable because of the withdrawal effects, because now you've upset their homeostasis. Same thing, people take things like Valium or Xanax to go to sleep at night. And they used to taking that every single night to go to sleep. What happens if I stop giving that to them at nighttime? Rebound insomnia, right? So again, this tolerance is kind of a double-edged sword, where if you take the drug away abruptly, you're going to see withdrawal sort of effects there. Now, how many of you are abusing caffeine currently? Surprised I don't see 64 hands in the air, but good on you if you're not, right? But anyway, my blood is, could probably be used for 5-hour energy after I die, so laden with caffeine. But imagine if you take away caffeine all of a sudden, what kind of effects do you see? Massive headaches, right? A lot of it has to do with cerebral vasodilation and things like that, causing a lot of pressure, causing a lot of headaches, but you feel miserable, right? Now, for instance, some of you are very caffeine sort of tolerant. If I give you, say, an extra shot of espresso, is it going to do very much for you? But nah, I can handle that any day of the week, right? Versus if you drink 12 5-hour energies or something, all of a sudden you get a lot of extra caffeine. It takes a lot more to get that same sort of oomph. Versus someone who, some of you, I guess, are very good and don't take a lot of caffeine. You will by the end of this, I guarantee you, but anyway, that's that. That's tolerance that develops over time. Now, again, if you were to wean someone off of those substances gradually, can they get back down to sort of normal baseline prior to ever being exposed? Yes, in some cases you can do that. In some cases it takes a long time. It depends on the degree of tolerance that is developed. Now, something that's kind of similar but distinctly different from tolerance is this process called tachyphylaxis. Now, in tolerance, as I mentioned with caffeine, I could give enough caffeine to eventually get that same sort of effect, right? Or if someone was using opioids chronically for pain, I could give them more of a dose. I could increase that dose and get more analgesia out of it, right? So I can overcome the tolerance with a bigger dose. Tachyphylaxis is a process that happens where you can't overcome that tolerance with dose. And you actually have to give the body time to recuperate itself a little bit before you'll get good effect out of that medication again. So you can see this with certain substances like amphetamines. What do we use amphetamines for? Anyone know? Adderall, Concerta, Vyvanse, ADHD. It's a very common place we use a lot of amphetamines. Also, people use it recreationally as well, right? So one of the things you'll find with amphetamines, the reason why it increases focus and increases heart rate and blood pressure is because it directly stimulates your neurons to release catecholamines like epinephrine, norepi, dopamine, right? Well, what happens if you run out of all those little vesicles for those neurotransmitters? I can give more amphetamines, but it's not really going to give me a whole lot of extra effect because I'm out of neurotransmitters. But by giving the body time to redevelop those neurotransmitters back, now they can give the dose of amphetamine again and it'll work, okay? Sort of an illicit sort of example of that, but the same thing happens with a drug called nitroglycerin, which we mentioned we use for what? Chest pain. One of the dosing things you'll find with nitroglycerin, especially the paste that they can put on, it says we'll use it for 12 hours on and then 12 hours off. I could use it 24 hours continuously, but the problem is that I deplete a lot of those cofactors that allow for the nitroglycerin to work, and thus it's not going to be all that effective. So when the patient develops chest pain and give them more nitro, it's not really going to do a whole lot. Even though I give them a ton of nitroglycerin, it's not going to do much. So that's why you have to build in what we call a nitrate-free period to allow their bodies time to kind of recuperate a little bit. Okay. So when do you think people would need that nitroglycerin on? Do you think it should be like on nighttime, daytime? Why daytime? So why does it matter more in the daytime?
Because you're going to experience pain more. It's going to be heavy.
Why would you experience pain more in the daytime though?
More blood flow.
More blood flow because of increased activity, right? So people are up and moving around during the daytime, they're physically exerting themselves versus when they're asleep at night. That could be one thing. However, if you have someone who works night shift, maybe they're want to put that on when they're working the night shift, right? When they're more physically active. So those things to consider, right? So that's a good example of tachyphylaxis. Even if I give more drug, can't overcome that effect, right? I have to give the body time to recuperate. And it could be a couple hours, it could be a couple days, depends on the situation. Okay, make sense? So again, different than tolerance. Tolerance I can overcome a dose. This one I cannot.
And this is like getting back your neurotransmitters,
In the case of like amphetamines, but yeah, so for instance with nitroglycerin, you have to build up back your stores of things like guanylyl cyclase and nitric oxide and things like that, yeah, for it to work again.
Would your margin of safety change at all still? You have to increase dosing?
Well, depends on the case, right? So for opioids, for instance, you will get tolerant to some effects, but not all the effects. So for instance, you don't get tolerant to the constipating effects of opioids. So as I keep driving up that dose there, the patient are just going to get more and more and more constipated, right? They never lose that effect based on how the drugs work. So you can find that depending on the drug and depending on the effect you're looking at, it can vary. Yeah. So again, it depends is ultimately the answer for most of the questions you're asking in class, unfortunately. But I'll try to elucidate a little bit further than that, but most of the time, it depends, right? Students hate that answer. I just want black and white, yes or no. Anyway, so some reasons why we can have variation in these responses here. So one of it could be due to alteration of the drug concentration that ultimately gets to the receptor. So less drug that gets to the receptor, less effect, right? You could have variation in the endogenous ligands. So if you're making more or less of an endogenous ligand that may compete for the same sites here, it could be a problem there. Alteration in the number or the function of receptors. So if I have fewer or more receptors that could affect it. And then we'll look at changes in some of the components of the downstream response, right? So in the case of nitroglycerin, it's a downstream of a response that we're seeing change there. I'll give you some more examples here. So looking at things that change the drug concentration at the receptor here, so this a lot of times has to do with the pharmacokinetic factors, right? So how am I actually absorbing, distributing, or metabolizing these substances? And then finally, how do I excrete them? By changing these can change pretty greatly how you're going to be able to, how much drug you actually get to that receptor site. So we'll cover this in more detail in the next section. But imagine if I were to say upregulate hepatic enzymes. And actually, most of you, if you enjoyed any barbecue during July 4th, some of you might actually have some upregulated hepatic enzymes. Actually, charcoal, broiled foods, and things like that actually can raise those enzyme levels. Side point, I'm not going to have to on that test. But anyway, whenever I upregulate hepatic enzymes, what do you think that does to drug metabolism? Is it faster or slower? Faster, right? Because I have more enzymes available to start to metabolize that drug. Well, there's actually a drug called carbamazepine. Anyone ever heard of this one before? It's Tegretol. These were seizures originally, but we use it a lot as a mood stabilizer for bipolar disorder. You see some other cases for it. But it has this process, what it calls autoinduction of its own metabolism. What do you think that means? And over time, it increases its own metabolism. So even though I keep giving the same dose of drug, you're actually going to see lesser and lesser effect because the body's metabolizing it more efficiently, more quickly. So how do I get around that? Well, I give a bigger dose over time. And actually, you'll find that when you're dosing that, when you start a patient out on it, there's a built-in titration schedule where we say, okay, give 100 milligrams a day on week 1, and then on week 2, you increase it to say 200, and then 300, and then 400. And at a certain point, there's a balance you hit there where the autoinduction is less of a factor, and thus you're now at a stable dose for that drug. Okay, but because the metabolism is happening more quickly, less drug gets to the actual target, and thus you may have more seizures, right? Or you may have swings in mood from bipolar disorder, things like that. Okay. Other factors are important as well. Things like age, gender, disease states, weight, all that can have a big role on in terms of how the kinetics of the drug has changed. And we'll talk about those ad nauseum the next time we're here. Okay. Other things that are important as well are changes in certain things like multi-drug resistant transporters. So certain transporters that are used normally to expel drugs out of the body are not working as well, and sometimes that leads to increased levels that can lead to some changes in response, things like that. As an example, you guys ever heard of like an interaction between grapefruit juice and certain drugs? Right? They say, hey, don't drink grapefruit juice with these drugs. And you're like, well, who would ever drink grapefruit juice? That stuff's gross. Who drinks grapefruit juice? Old people drink grapefruit juice, right? It's like the only thing that tickles their taste buds anymore, right? My grandparents had a whole grapefruit tree. They produced all these grapefruits, and they're the only people that ate it because all the rest was like, it's gross. But the reason why it was so much of a problem for them is because it would actually inhibit certain hepatic enzymes and inhibit some of these transport proteins. And that would actually lead them to expel less drug, and thus their levels would build up, and that leads to what? Toxicity, right? So that was a big interaction that I'd actually watch out for. And that's why you ever see that. Don't drink a grapefruit juice. It's because of these kinetic sort of interactions. More drugs getting to the site, more toxicity can occur there. Okay. Other cases here, you actually find cancer cells will develop resistance to certain cancer drugs. They can do the same thing. They can sort of upregulate these proteins here and make the drugs less effective, right? Now, how about the endogenous ligand concentration? So propranolol is a drug that is commonly known as a beta blocker. Right, so what do you think a beta blocker does? Blocks beta receptors, right? Beta receptors normally do what for us? Speed up heart rate, help control blood pressure a little bit, as part of that fight or flight response, okay? Now, propranolol can sometimes be given for patients who have like chronic hypertension, but you may find people who are relatively young and healthy, have no real disease states, are taking a beta blocker. Anyone know why they might do that? Stage fright, right? Or for performance anxiety. So imagine right now you're sitting here, kind of calm and chill. My dulcet tones are lulling you off to sleep, right? I start to see some of those delta and theta waves start to pop up a little bit. Anyway, point being is that right now you're in kind of a low stress sort of state, right? Your fight or flight response hasn't really kicked in. I can give you a beta blocker, but because you're not releasing a lot of catecholamines, it probably is not going to give you a whole lot. It's not going to cause a lot of effects, right? Because your beta receptors aren't really that active in the first place. However, if I said, again, one of you come up here and give the rest of this lecture, all of a sudden fight or flight response kicks in, heart rate goes up, you start to sweat, you start to get tremulous because now the beta receptors on the skeletal muscle start to get activated. Now, if I give you that beta blocker, what do you think it would do? It decrease your heart rate because your release is blocking all that epinephrine from interacting with the receptors. It helps with the tremulousness, helps with the diaphoresis. And that way you can get up here, and even though you may feel nervous, you physically won't be showing it, right? Again, because now you're in a high endogenous ligand state where you're releasing a lot of those catecholamines, but the drug is doing its job and it's blocking those effects there. Does that kind of make sense? So depending on the clinical situation, drugs may be more or less effective depending on kind of what the patient is doing in terms of their own physiology. Okay. Now looking at the change in numbers of receptors, remember we talked about upregulation and downregulation. When do you think you would upregulate receptor numbers? When I'm blocking them or activating them? When I'm blocking them, right? Because again, typically when you're blocking them, the receptors are like, hey, I'm not getting activated enough. Let me try to get more receptors up to the cell surface in order to reestablish homeostasis, right? Now, if I'm constantly activating the receptors, they're saying, well, there's too much activity here. What does it do in response? Well, downregulate those receptors, right? So it's important to keep that relationship in mind there because you can find that depending on how things are upregulated or downregulated, you may find the effects can be pretty greatly different. So imagine, especially even hormones can have huge effects on this. So as an example, imagine thyroid hormone. When someone who is hyperthyroid, how do they kind of normally appear? Are they like a high metabolic state, low metabolic state? Usually pretty high metabolic state. It might be sweating a lot. It might be, their sympathetic nervous system is kind of upregulated because the receptor numbers have changed based on the effect of thyroxine throughout the entire body, right? Versus someone who is, say, hypothyroid, how do they normally appear? Cold, kind of sluggish, they feel tired, right? Some of you might feel like you're hypothyroid right now, right? It's just me, don't worry. But again, a lot of it has to do with the thyroxine effects on the receptors that are actually being expressed and how responsive you might be to things like epinephrine, right? And so again, you can find that tachyphylaxis and tolerance can be a result of some of these reduced number or the functioning of the receptors themselves. So sometimes up or down regulation can play a role in these concepts as well. So sometimes that's the background of what's happening there. Okay. Desensitization. This is where basically by constantly giving a drug, you may actually find that you get lesser and lesser effects out of that receptor, because they basically become desensitized to it, right? It gets to the point where it just cannot be reactivated for a period of time. It undergoes what we call a refractory period. Anyone know what a refractory period is? So it doesn't matter how much stimulus you give it, it needs time to really reactivate itself a little bit. So when you think about things like the cardiac conduction cycle, those sodium channels have a refractory period. And that's really important because if it didn't, what would happen? You would die of ventricular arrhythmia, right? So it's important to have those refractory periods to make sure new action potentials don't get triggered. You don't have an arrhythmia. Yes, ma'am.
What's the difference between tolerance and desensitization?
So tolerance is something where I can continue giving bigger and bigger doses, and I can overcome the tolerance, right? So if I have someone who's on, say, 40 milligrams of oxycodone a day for chronic back pain, and they're coming back, and man, I'm still just having a lot of pain. Like it's just not working for me anymore. That sometimes can trigger you off to think, okay, well maybe it's not working for them anymore because they are tolerant to that dose. And then if you bump it up to 60 a day, now it's like, wow, I feel much better, right? Because you overcome that tolerance there. Desensitization is much more in terms of like the tachyphylaxis a little bit, where you see that diminished response, and sometimes you get down to almost no response whatsoever. I'll give you a good example of this. So if you have to intubate a person, right, so you have to breathe for them, you want to make sure you basically paralyze all the muscles in the larynx. That way you can actually pass the tube through, right? So we have to give a paralytic in order to get that through, to facilitate that, right? So there's a paralytic called succinylcholine. Sometimes if you ever hear it called sucks, or if you hear like the second years, they're doing ACLS right now, they're probably talking a lot about sucks. Succinylcholine is a drug there. Basically what it does is actually when you give it, it will activate nicotinic receptors on the muscles, and it actually initially will cause fasciculations. So you may actually give it to a patient and see them kind of jitter around a little bit. And then it desensitizes those receptors. to where they're not working at all. So what happens if I make all your nicotinic skeletal muscle receptors stop working? You become paralyzed. So all of a sudden because the receptors are not desensitized, now those receptors can't work anymore. Now you're paralyzed. You stop breathing on your own, but now I can get that tube through. You can then start to breathe again, or we'll breathe for you essentially. Okay, so that's a form of desensitization that actually comes up clinically, right? Anyway, typically the reason why your receptors do this is to prevent overexcitation of the cells, because that can lead to cell excitotoxicity, can lead to cell death potentially. So that's why we end up doing that as a natural defense for our cells. Okay. So again, oftentimes this phenomenon can be described as tachyphylaxis. Again, clinically, you can kind of think about the two together there. By giving the patient a period of time without the drug, you'll find that the receptors will resensitize. May take a few hours, may take minutes, depending on the drug situation. But again, you're going to find that the receptor's still there, they're just not working as well. But by giving it a drug-free period, they'll get back to baseline, and then that drug will be just as effective as it was before when you give it the next time. Okay. Here's an example of what that would look like, where again it appears after the first dose, you give a second one, the drug would become less effective. But if you give it a period of time, say like an hour or two, the drug would regain the efficacy back essentially. Okay. Okay. There's a phenomenon called rebound phenomenon. It's kind of a withdrawal sort of effect you can sometimes see due to changes in the number of receptors you can see there. So imagine I'm giving the drug propranolol. We said it's a beta blocker. So it's blocking up your beta receptors, say for instance on the heart. Okay. Which beta receptors lie on the heart mostly? Beta 1 or 2. Remember, you got one heart, you got 2 lungs. Beta 2 in the lungs, beta 1 in the heart. That's how I remember it, right? Or that's how I used to remember it back when I was in school and I was trying to engulf all this information, right? But anyway, so typically this will lead to lower heart rate, lower blood pressure, and we said by blocking these receptors, what do you think the number of receptors would do in response to that? They upregulate or downregulate? They're going to upregulate, right? Because they say we're not getting activated enough. We need more epinephrine receptors here, more beta 1 receptors to get activated. And so typically you'll find that there's enough drug around to actually deal with those receptors and everything is good, right? Everything is fine. But what happens if I take that drug away all of a sudden? Now I got all these receptors that are there. There's no drug around to block it, and they're going to be very, very responsive to that epinephrine, that norepinephrine that gets released onto it. And so what do you think it could cause as a rebound effect? Rebound tachycardia, rebound hypertension because of the withdrawal effect. So imagine here, again, your drug or your normal epinephrine, say, is going to be these green triangles here. Here's your beta receptors in the blue. Here's your cell membrane. So imagine right now the heart rate 75, blood pressure 145/90. We start them up on a beta blocker. So you're going to block those off. Say your heart rate comes down a little bit, blood pressure comes down, everything's looking all hunky-dory, right? Now the cells respond by upregulating the number of receptors that are available. So it says, okay, let's put some more receptors on the surface here. Maybe we'll get more activation. We'll get back to a normal homeostatic baseline. But then I take the drug away all of a sudden. Now what happens? Now you get rebound hypertension and tachycardia. Might not be a problem for your patient, but there's been cases where MIs have been induced because of this sudden abrupt withdrawal of these medications there, where they ran out or they forgot their meds or something like that, and they come into the ER having a heart attack potentially. So these are things you have to really be considerate of and make sure that they know, hey, you can't just stop taking this medication all of a sudden. You need to make sure, let me know if you want to stop. We can talk about weaning off, we can taper it, whatever we need to do to get you off that medication there. Okay. Another good example of cases here we have to worry about like rebound phenomenon and things like that. Could be cases where, for instance, the opposite can occur. So imagine if you're having like an asthma attack or something, or if you're have some sort of inflammatory condition, I can give you corticosteroids in order to deal with that. It's kind of a different process essentially, not with the receptor number, but if I give you corticosteroids, what do your adrenal glands do in response to that? Yeah, all these steroids flood in your body. The adrenal gland's like, well, do I need to really release steroids? I said, no, not really. So you can actually have adrenal trying to think, my words are now escaping me now that I'm right at the end of the lecture there. You can have adrenal atrophy that could actually occur there. Thank you. So the adrenal gland can atrophy in response to all these corticosteroids because it's like, we got enough around, we don't have to do anything. We're good. You know, we're an easy street, taking a vacation. But what happens if they're on it for a while and all of a sudden you take away those corticosteroids? Is your adrenal gland just going to perk back up and say, all right, let's start producing cortisol again? No, it takes time. And so you can actually put people into adrenal crises because you did not wean them off appropriately. So we'll talk about those in the individual situations where it becomes important. But just know this rebound phenomenon can occur in kind of both situations, right? Either by blocking things or by potentially providing excess of a substance. Right? So, 2 or 3 more minutes. I'm going to cut it off here. Let me check the board real quick to see if there's any questions. Any questions so far? Like to voice them themselves? No, how many more slides do I have? 10? Yeah, I'm not going to be able to get 10 slides in. It's crazy. Oh, I have some questions, though. Fantastic. I do have time for this. Okay, so let's say there's an associated mutation with the gene for red hair that makes them more sensitive to analgesics. Is this an example of an idiosyncratic drug response? Yes, I would consider this to be probably an idiosyncratic response, right? So again, if there's sort of a co-mutation that happens there where they tend to be, and again, I'm not actually aware of this, so this could be total fluff. I have no idea. I've not looked into it myself. But let's say you do have that co-mutation that happens there where they tend to be more sensitive. That would be something to consider. So maybe if you walk into the room and you see a patient has red hair, you're like, wait a second, maybe they're more sensitive. You may start at a lower dose to make sure they don't get that toxicity potentially, right? Something to consider. Good question, though. How much caffeine will kill you? That's a really good question. There's a website. It's called Death by Caffeine. Find that right. Yes, Death by... I can't spell it right, but Google will help me out. I think this is it, right? So you select your type of drink. So I want to drink coffee, all different kinds. Oh my god, it's very specific. They've updated the sense. Let's look at Folgers. You can put in your weight. I'm not going to put in my weight, but let's say we're doing a prototypical, let's say 175-pound man or woman. Calculate your limits. So this daily safe maximum lethal dose, you'd have to drink 106.6 cups. If you just drink 106, you're okay. No problems. But that 0.6 will do you in, right? Now, very frequently, it's a lot of coffee, right? You would clinically probably die of like overhydration or something and like hyponatremia before you'd actually die from the actual caffeine overdose. So that's not a very concentrated form of caffeine, but let's say we're typing something like no-dose. So no-dose, anyone familiar with those? Call it trucker speed sometimes because they're basically tablets of caffeine they would use to stay awake and drive for longer. But it only takes about 60 tablets to put you down. That's a much more reasonable amount someone could potentially ingest. Not that I would recommend that. But again, that's to kill somebody. Like, obviously, they would be very toxic well before that point. So it's not to say that, as long as you just drink 50 cups of coffee, you're good. Like, no, they're probably still going to be pretty sick before that point there as well, right? So anyway, to answer your question, go to the website. You can find out, right? Everything is on the internet. You just got to find it. Okay, and then the last question. So ED50 is not the same as half-life. No, they're very different concepts. We will cover half-life much more specifically in the pharmacokinetics section. Anyone know what half-life means? The time it takes to metabolize half of the amount of drug that's within the body, right? So we'll cover that in much greater detail later on, but I am out of time, so I'm not going to do that. But if you have any other questions, let me know. Otherwise, I will see you guys Thursday? I think Thursday. All right, be back by 12:30.